Pleasure to be here with you in Egypt, my first trip here. It's very exciting, and it's nice to have an opportunity to review the data that we have in premenopausal women with ER-positive metastatic breast cancer. So as you're well aware, the NCCN guidelines put a very large emphasis on endocrine therapy and giving 3 consecutive lines of endocrine therapy before considering chemotherapy if patients are still benefiting from endocrine therapy. After 3 lines, we continue endocrine therapy, and only if they have not benefited from 3 lines of endocrine therapy and they don't have significantly symptomatic disease do we then switch over to give them chemotherapy. So as we just heard from Professor Hamdi, really the emphasis in ER-positive breast cancer really is on endocrine therapy sequentially and putting off chemotherapy for as long as we possibly can. And the NCCN gives us a long list of options up here. The NCCN does not tell us what we should start with and how we should sequence, but they give us quite a good list of options to choose from. But as you well know, there have been very few randomized phase 3 clinical trials conducted in premenopausal women with hormone receptor positive, HER2 negative metastatic breast cancer. In the U.S. in 2017, approximately 19% of invasive breast cancers were diagnosed in women aged 49 and under. And in the Asia-Pacific region, the proportion of patients aged under 50 diagnosed with breast cancer maybe up to 42%. So it's not a small percentage of patients. The last randomized trial focusing solely on premenopausal women with metastatic breast cancer was published in 2000 by Jan Klein, looking at LHRH agonist plus tamoxifen in combination. Young women with metastatic breast cancer have a distinct tumor biology, more aggressive disease, and are more likely to die from their cancer than older women. Endocrine therapy with ovarian suppression is the recommended first-line treatment for premenopausal women with hormone receptor positive, HER2 negative metastatic breast cancer. However, of course, resistance and disease progression ultimately occur, and these patients need better options than we have had for them heretofore. These are the ASCO endocrine therapy guidelines for premenopausal women with metastatic breast cancer. These are published in 2016, and in the red box you see that ovarian suppression is recommended regardless of whether the patients are essentially de novo metastatic with no prior adjuvant endocrine therapy. And note here that in the first line setting, it's ovarian suppression with an AI is a non-steroidal AI is preferred. And then in the second line setting, fulvestrant and palbociclib is recommended based on the Paloma 3 trial, which did have a premenopausal cohort. In patients who have had prior adjuvant endocrine therapy, if they had prior tamoxifen, then ovarian suppression and a non-steroidal AI is recommended for the first line, and again, fulvestrant and palbociclib. Second line, if they had a late relapse, more than 12 months since adjuvant therapy and prior tamoxifen, again, ovarian suppression and a non-steroidal AI. If they had prior therapy with an AI and ovarian suppression, then it's ovarian suppression plus fulvestrant and palbociclib. And if they had a later relapse, it's ovarian suppression and a non-steroidal AI. So we see that according to the ASCO guidelines, that it is not the inclusion of a CDK4/6 inhibitor plus an AI plus ovarian suppression as of 2016 for the simple reason of lack of phase 3 data showing benefit from CDK4/6 inhibitors in this patient population in the first line setting. Let's just review the data we do have, which is very little with regard to phase 3 trials. And Jan Klein and colleagues conducted a randomized trial of first-line metastatic ER-positive premenopausal breast cancer patients randomized to tamoxifen versus the LHRH agonist buserelin versus tamoxifen plus buserelin. And we see that there was a statistically significant, large, more than a year improvement in median overall survival with the combination of buserelin and tamoxifen. And the curves here on the left show the overall survival curves, adding tamoxifen to buserelin versus buserelin alone. But probably the most important comparison was tamoxifen alone versus tamoxifen plus buserelin, and as you know, a large survival advantage in favor of the combination, which made this become the first-line choice for ER-positive premenopausal patients. There was a study in the JCO in 2010 that was just a phase 2 trial, about 73 patients here, 35 premenopausal, 38 postmenopausal, and this was combining goserelin with letrozole in the premenopausal population, and it was letrozole alone, of course, in the postmenopausal population. And we see here for tumor response, excellent tumor responses in the premenopausal women, similar to the postmenopausal. Time to progression, the same, and overall survival, the same. So small phase 2 trial, but giving us confidence that an LHRH agonist plus aromatase, non-steroidal aromatase inhibitor appears to be as effective in premenopausal women as letrozole is in postmenopausal women. As Professor Hamdy just told us, cyclin D1 and CDK4/6 are really the proliferative machinery of ER-driven breast cancer. The estrogen receptor leads to the transcription of cyclin D1, and cyclin D1 complexes with CDK4/6 and drives the cell cycle. And so when we inhibit CDK4/6 and the estrogen receptor together, we're really clamping down very hard on the two very, very important axes in ER-driven breast cancer. So very, very excellent downstream nodal point. CDK4/6 is downstream from PI3 kinase, MAP kinase, JAK-STAT, a number of mitogenic stimuli. Cyclin D1 and CDK4/6 are downstream, but importantly, the estrogen receptor itself leads to the transcription of cyclin D1 to drive the cell cycle. So it makes a great deal of sense to have simultaneous inhibition of both of these nodal points in ER-driven disease. As you know, there are now 3 FDA-approved CDK4/6 inhibitors. The palbociclib is approved both first and second line. Ribociclib is approved first line with letrozole. We await the data from the Mona Lisa 3 trial with fulvestrant, which should be coming soon. And abemaciclib is approved with fulvestrant second line, and then later line after chemotherapy in the metastatic setting as a single agent later line, and we await FDA approval of first line based on Monarch 3 with letrozole. This shows the summary of the excellent results that Professor Hamdy has already gone over, with an approximate doubling of PFS. And of course, as he pointed out, these are definitely the longest progression-free survivals we've ever seen, really, outside of HER2-positive disease, in ER-positive disease, with 24 months median progression-free survival. Very, very excellent results right across the board with all 3 of the CDK4/6 inhibitors first line. So at San Antonio, we heard the Mona Lisa 7 data presented by Dr. Debu Tripathi, focusing on premenopausal women, first-line metastatic ER-positive disease. And these women were allowed to have had 1 or fewer lines of chemotherapy in the advanced disease setting, 672 patients, no prior endocrine therapy, however, for metastatic disease. They were stratified by the presence of visceral disease versus not, by prior chemotherapy for advanced disease or not, and whether they would have the endocrine therapy partner for their first-line treatment of either tamoxifen or a non-steroidal AI. And it was a 1-to-1 randomization. All the patients received goserelin every 28 days, and they received either tamoxifen or nonsteroidal AI of physician's choice, randomized to placebo or to ribociclib. And the primary endpoint was locally assessed progression-free survival. We see that the patients were a median age of 43 and 45 years. About 30% were Asian, 40% were de novo metastatic, and down the bottom, about 14% of patients had had chemotherapy for advanced disease. 40% had had chemotherapy in the adjuvant or neoadjuvant setting, and about 45% of patients had had no prior chemotherapy. This is the primary endpoint of progression-free survival, and the median progression-free survival in the endocrine therapy and goserelin alone arm without the ribociclib was 13 months, and that improved up to 23.8 months with the addition of the ribociclib, and the hazard ratio is 0.55, and that was highly statistically significant. So the results look very, very similar indeed to what we just saw from Professor Hamdy in Mona Lisa 2. Looking at whether the patients received tamoxifen or a nonsteroidal AI, we see down the bottom that the hazard ratios were the same, regardless of whether the patients received tamoxifen or the nonsteroidal AI. The median progression-free survivals, both in the endocrine therapy alone arm and in the ribociclib arms, were a little bit higher with the nonsteroidal AI, as we would expect, but the relative reduction in the risk of progression was decreased similarly whether the patients received tamoxifen or a nonsteroidal AI. There was a blinded independent review committee that also took a look at 40% of the randomized patients, and you see that the results held up very well in the blinded independent review. Looking at the forest plot, again, as we've seen in Mona Lisa 2, and in fact, all of the first-line trials of CDK4/6 inhibitors, all of the patient subsets did benefit from the ribociclib, including down the very bottom here, the de novo metastatic subset, again, with a hazard of 0.428, a very, very good benefit for patients with de novo metastatic disease, as we just heard with regard to Dr. Mona, who had the de novo metastatic. So all of the patients, visceral disease, bone-only disease, et cetera, all patients benefited approximately equally from the addition of the ribociclib. The objective response rate was 50.9% in patients with measurable disease, again, very similar to the postmenopausal population, and the clinical benefit rate was about 80%. So the vast majority of patients had benefit. Overall survival data remain immature at this time. There were no surprises at all with regard to toxicities. They basically are exactly what we just heard in the postmenopausal group: febrile neutropenia, 2% in the ribociclib arm, 0.6% in the placebo arm. There were really nothing in the way of non-hematologic toxicities that were any surprises, and they really were of not any particular note. Post-baseline QTc, more than 480 milliseconds based on EKG, was 6.9% in the ribociclib arm versus 1.2% in the placebo arm, and a post-baseline QTc more than 500 milliseconds in 1.5% of ribociclib patients versus 0.3%. Treatment discontinuation due to QTc prolongation only in one patient on the ribociclib arm and 2 patients on the placebo arm. So it wasn't an observation that was of clinical significance. There was not any associated clinical symptoms nor arrhythmias. So really not a clinical issue to my way of thinking. With regard to time to deterioration of quality of life, you see in the top curve there was a slower time to quality of life deterioration, more of a sustained benefit in quality of life with the ribociclib. And also down the bottom, there was a clinically meaningful improvement from baseline in pain score as early as 8 weeks, as we just heard as well, in the postmenopausal setting. So the Mona Lisa 7 trial was the first phase 3 trial in premenopausal women with a CDK4/6 inhibitor. It showed PFS significantly prolonged, as we would expect, and it didn't make any difference whether the patients had a non-steroidal AI or tamoxifen. And the treatment benefit was the same across all of the patient subsets, and the toxicity profile was predictable and manageable. There was a clinically meaningful improvement in time to deterioration of quality of life and improvement in pain score. And so ribociclib now, combined with either tamoxifen or a non-steroidal AI with goserelin, is a potential new treatment option for premenopausal women with hormone receptor positive, HER2 negative breast cancer, regardless of disease-free interval or the endocrine partner. And I certainly would agree with this. This is certainly level 1 evidence. Now, palbociclib and abemaciclib, we have seen data with regard to the second line in combination with fulvestrant. You're very well aware of this. And again, more than doubling the duration of progression-free survival with the CDK4/6 inhibitor added to fulvestrant. And there has been a look and a separate publication by Sibylle Leubel in The Oncologist, just 2017, looking at the premenopausal population in Paloma 3. It was 108 women in Paloma 3, fulvestrant, with or without palbociclib, who were premenopausal. And we see on the left, we see the objective response rate, and on the right, we see the clinical benefit rate. And we see that the premenopausal women have a greater response rate and a greater clinical benefit rate with the fulvestrant, and they were also receiving an LHRH agonist along with the fulvestrant and the placebo versus the palbociclib. This looks at investigator-assessed progression-free survival in the premenopausal subset in Paloma 3. And on the top, you see all premenopausal women, 108 women. In the middle, we see the premenopausal patients who are age 50 or younger. And then we see down the bottom the postmenopausal women who are age 50 or younger. And we see the hazard rates are all around 0.5. The premenopausal women had the same benefit as the postmenopausal women in the second line therapy with the palbociclib and the fulvestrant. Interestingly, down the bottom, in the Paloma 3, there was a single data point on day 15 looking at biochemical plasma analysis for LH, FSH, and estradiol. And I've circled down the bottom there the estradiol, and the palbociclib is in blue, and the placebo is in yellow. And most of the patients were at 0 on their estradiol levels. This is picograms per ml. Most were at 0, but about 10 to 15% of women were at 15 or above. And Dr. Mitch Dowsett tells us that we should be aiming for a 2.72 picograms per ml because that's the average estradiol level that a postmenopausal woman achieves on an aromatase inhibitor. So there is a little bit of concern in the premenopausal population with the LHRH agonist, even given optimally every 28 days. It's difficult for patients to get in every 28 days to receive their LHRH agonist. So for some patients, oophorectomy may be preferable if they have, if this is an acceptable option for the patient. So in summary, for premenopausal patients, we want to add an LHRH agonist to endocrine therapies that have proven benefit in postmenopausal women. The addition of an LHRH agonist to tamoxifen first line in premenopausal women improves overall survival. Letrozole and an LHRH agonist are similarly effective in pre- and postmenopausal patients. The addition of ribociclib to first-line goserelin with tamoxifen or nonsteroidal AI improves progression-free survival versus endocrine therapy alone considerably. Very substantial improvement in both the tamoxifen and nonsteroidal AI groups. The addition of second-line palbociclib to an LHRH agonist plus fulvestrant also improves progression-free survival substantially. And thankfully, the premenopausal patients are eligible for the ongoing adjuvant CDK4/6 inhibitor trials. Thank you very much.
Thank you very much. I think we'll leave the questions to the end of the session. Thank you.